Welcome back to the deep dive. Today, we're doing something a little different. We are getting right into that specific headspace of a post-grad student at like 3 in the morning.
I know that feeling all too well.
You know it, right. The coffee is stone cold. You've got Miller's Anesthesia open on one side, the Oxford Handbook on the other, and you're staring at a topic that looks, I don't know, deceptively easy, but is actually a total trap.
The classic wolf in sheep's clothing topics, they look simple on the syllabus, but they are absolutely where exams are won and lost.
Exactly. And the topic is anesthetic management for upper GI endoscopy and colonoscopy. And honestly, my first thought was, it's just a bit of sedation, right? How hard can it be?
And that's the first mistake.
But then I started digging into these notes you sent over, specifically the sections on RRA, non-operating room anesthesia, and I realized this is actually a minefield.
It is, and that's exactly why examiners love it. If you walk into Aviva thinking it's just a bit of Propofol, you will fail. I can guarantee it. The exam question isn't really about the endoscopy itself. It's about how you manage a compromised airway in a dark room with limited help on a patient who might be actively bleeding. It tests your crisis resource management just as much as your pharmacology.
Yeah, Miller really emphasizes the hostility of the environment. It's not the pristine OR we're used to.
Not even close.
So the goal today, our mission, is to synthesize these heavy texts into that perfect 15-mark answer for the Gujarat University MD Anesthesiology exams. We need to build the structure. Pre-op, intra-op, the specific pharmacology, and of course, the disaster management.
Right, and there's a core tension we need to keep coming back to, a central theme. And that's the concept of the shared airway.
Okay.
In almost every other surgery, the anesthesiologist owns the airway. It's our domain. But in upper GI endoscopy, you're renting space. You're renting it from a gastroenterologist who is actively, if unintentionally, trying to obstruct it.
That's a great way to put it. So let's kick this off. Part A, introduction and exam framing. If I'm sitting in the exam hall, I turn over the paper, and I find a long question on this. How do I even start? Do I just define the procedure?
You start by defining the scope, yes, but you do it to show you understand the clinical context. So you'd write, upper GI endoscopy, often called EGD or OGD, involves the visual examination of the esophagus, stomach, and duodenum. Then, colonoscopy is the examination of the lower GI tract, from the rectum to the cecum, and sometimes the terminal ileum.
Okay, simple definitions.
But you must immediately pivot to the purpose. Don't just say what they are, say what they're for. These are diagnostic and therapeutic procedures.
Therapeutic, meaning they might be clipping bleeds or removing polyps or something like that.
Exactly. And that single word, therapeutic, changes the entire anesthetic risk profile instantly. But the most critical part of your introduction, the part that gets you the marks, is to classify this under NORA, non-operating room anesthesia. You need to write that acronym down and define it.
Okay, N or R.
Miller makes a very, very strong point here. NORA is a rapidly growing field, and it often involves sicker patients, ASA 3 and 4 in what it calls remote locations.
Let's unpack that remote location aspect a bit. In the exam, why is that a point worth marks? It's still in the hospital, right?
It is, but remote in this context means remote from the safety and resources of the main operating theater. It implies risk. You're working with limited space, for one. The room is designed for the gastroenterologist, not for us. The lighting is dimmed for their screams.
Which means you lose visual cues, you can't see the patient's color properly.
Precisely. You can't see cyanosis. And the support staff are endoscopy nurses. They are brilliant at what they do, but they are not trained in anesthetic emergencies in the same way an OR technician is. You are often physically isolated from backup.
So if things go south, you are basically on an island.
You're on an island, and you need to have brought all your equipment and plans with you. That directly leads back to the shared airway concept we mentioned. In EGD, the endoscope itself is a foreign body. It's an airway obstruction.
It's sitting right there in the pharynx.
It triggers the gag reflex. It can cause laryngospasm.
Right.
You can't easily get a seal to mask ventilate with a scope in the mouth. This competition for space is the defining anesthetic challenge. If you don't mention shared airway in the first paragraph of your answer, you've missed the entire point of the question.
Got it. Okay. What about other exam patterns? Where else does this topic pop up besides the long question?
Oh, it's everywhere. You'll see it in short notes, usually phrased as sedation challenges in colonoscopy or maybe NORALA safety principles. But the viva is where they really get you.
Of course.
In a viva, they won't ask you to list facts. They'll present a scenario. You have a 70-year-old male for an ERCP, 5 minutes in, his saturation drops to 85%. What do? They want to see your thought process. They want to know you are safe.
Your crisis management algorithm.
Exactly. They're testing your ability to think under pressure, far from your usual environment.
Okay, this is making a lot more sense now. Let's move to Part B then. Procedural characteristics and challenges. So, to write a good answer, I need to think like the gastroenterologist for a second. What are the key procedural characteristics I need to list out?
First thing is duration and invasiveness. Usually these procedures are short, 10 to 30 minutes. But, and this is a big but, they are highly variable. A quick diagnostic look is one thing. A complex therapeutic ERCP can take hours.
So the anesthetic plan has to be flexible.
Has to be.
Yeah.
And generally, the surgical stress is minimal. It's not like a laparotomy.
Yeah.
And that's why we get lulled into this false sense of security.
Right. And positioning is a big one. I see references to this everywhere in the Oxford Handbook and Histos. It's not supine usually.
No, and you must know this. This is a key exam detail. The standard position for both EGD and colonoscopy is the left lateral position. It's also known as the Sims position. You have to write that down.
Okay, left lateral. Let's really visualize the setup here. We know the standard position is left lateral, and that obviously helps the endoscopist get access. But looking at the sources, there's a massive anesthetic safety angle here too, right? It's not just about their convenience.
Crucially, no. It's not about convenience at all. It's about physics. It's about safety. Think about the physics of aspiration for a moment.
Okay.
In the supine position, gravity is working against you. Any regurgitated content, any fluid, pools at the glottis and can just fall straight into the trachea. It's the worst possible position for an unprotected airway.
But in the left lateral position,
Your mouth is now lower than your larynx. The corner of the mouth becomes the lowest point. So you're essentially using gravity as a passive suction device. Anything that comes up will tend to drain out of the mouth rather than down into the lungs.
which is a huge safety buffer if you're doing deep sedation without an endotracheal tube.
It's your single biggest safety buffer against aspiration in that scenario. But, and this is how you show the examiner you're thinking at a higher level, there is a trade-off.
Okay, what's the downside?
While the airway is safer from aspiration, your monitoring becomes harder. You can't easily see chest excursion, can you? The patient is on their side, they're covered in drapes. And physiologically, you have to be very careful about VQ mismatch, especially in obese patients.
VQ mismatch. That's ventilation perfusion. Why is that worse here?
Because the dependent lung, the left lung in this case, is being compressed.
Right, by the weight of the other lung and the mediastinum.
And by the abdominal contents pushing up on the diaphragm, so your functional residual capacity, your FRC, drops significantly in that lung. If you have an obese patient, their FRC is already low. That dependent lung might be atelectatic before you even start the procedure.
Which means they have less oxygen reserve. They'll desaturate much faster if they become apnoic.
Seconds, not minutes. So when you write the answer for positioning, don't just write left lateral. That's a pass. You write, the left lateral position is utilized for both endoscopic access and to minimize aspiration risk via passive gravity drainage. However, it can compromise visual monitoring of respiration and may reduce FRC in the dependent lung, thereby accelerating the onset of hypoxia during apnea. That is the distinction between a pass and a distinction.
That's a fantastic point.
Okay.
Okay, now let's talk about stimulation levels. Is it actually painful?
It depends on which end you're looking at. And this is a nuance examiners love. EGD, an upper GI endoscopy, is not painful in the somatic sense. It's not like a skin incision. But it is intensely stimulating.
How so?
Insertion of the scope triggers the glossopharyngeal and vagal nerves. That's your gag reflex and your laryngeal reflexes. The body's primal response is to cough, gag, and fight it.
So for EGD, you need reflex suppression more than you need pain relief.
Exactly. You need to obtund the gag. You need to make the body tolerate this massive foreign object. Colonoscopy, on the other hand, is a different beast entirely. Colonoscopy causes true visceral pain. This comes from two main sources: gas insufflation, stretching the bowel wall, and traction or torque on the mesentery as the scope navigates the bends of the colon. It's a cramping, deep, poorly localized pain. So, to summarize for the exam, EGD requires reflex suppression, colonoscopy requires analgesia and anxiolysis.
That's a very clear distinction. That brings us to the big topic, anesthetic challenges. We've mentioned ORAR and the shared airway. What else is really high yield here?
Hypoxia. You need to write that in capital letters. It is the #1 adversary in the endoscopy suite. And remember what we said about the environment. You often working in a darkened room.
Right, so they can see their monitor.
which means, as Miller emphasizes, clinical observation of cyanosis is almost impossible. You cannot rely on looking at the patient's lifts or nail beds. You rely strictly, and I mean strictly, on your monitors, specifically the pulse oximeter and the capnograph.
We'll come back to monitoring in detail. What about aspiration? This seems a bit controversial. These patients are technically fasting usually, so why do we treat them as high risk?
Do not, under any circumstances, tell an examiner the risk is low. That's a major red flag. Miller's crystal clear on this. There are several reasons. First, you have gastric insufflation. The endoscopist is actively pumping air into the stomach to see. What does that do?
It increases intragastric pressure?
It blows the stomach up like a balloon, making regurgitation more likely. Second, many of these patients have underlying pathology. They're not healthy volunteers. They have GERD, a hiatus hernia, esophageal strictures. Their lower esophageal sphincter is already incompetent.
And if they're actively bleeding?
That's the trump card. That is the absolute indication. If a patient is having an upper GI bleed, that is a full stomach scenario by definition, regardless of when they last ate. Blood is a potent emetic. It irritates the stomach lining. So if you are doing an emergency scope for a bleed, you must assume they will vomit. You treat it as a rapid sequence induction.
Okay, that clarifies a lot. Moving on to Part C, preoperative assessment. This is listed in our notes as absolutely essential. So if I skip this in Aviva, I fail, right?
You fail immediately, without question. Safety begins before the patient even enters the room. You cannot fix a lack of preparation with agility and skill inside the room. It's too late by then.
So what are we looking for in the pre-procedure evaluation? Where's the focus?
You start with the airway assessment, always. Morgan is insistent on this. You must document the Mallampati score, thyromental distance, neck mobility, and mouth opening. The full assessment.
But wait, here's a question I've always had. If we're not planning to intubate, if the plan is just sedation, why does the Mallampati score even matter?
That is the trap. That is exactly the trap a junior resident falls into. You assess the airway not for your plan A, but for your plan B, C, and D.
Ah, for the rescue.
Always for the rescue.
Yeah.
If your sedation plan A fails, or if they obstruct and you suddenly can't ventilate them, you need to know immediately if this is going to be a difficult intubation. You do not want to be discovering a Mallampati 4 airway with a receded chin after you've pushed a bolus of Propofol and the saturation is plummeting to 60%.
That makes perfect sense. Always prepare for the rescue. Okay, what about comorbidities? What are the big red flags Miller points out?
The biggest one, and it's huge in all the neuro literature, is obstructive sleep apnea, OSA.
Right.
These patients have a collapsible pharyngeal airway. That's the definition of the disease. When they sleep at night, they obstruct. When you give them even a whiff of a sedative like Propofol or Midazolam, what do you think happens?
They obstruct. Instantly.
Instantly and completely. Miller strongly suggests using a screening tool like Stop at Bang. If they are high risk for OSA, you need to be much, much more cautious with sedation. You might even decide GA with a secure airway is the only safe option.
And cardiac disease.
For cardiac disease, look at their functional status. Can they climb 2 flights of stairs without getting breathless? What's their MET T-score? Miller notes the risk of ischemia. The procedure itself can cause stress tachycardia, hypertension, and a colonoscopy can cause profound vagal stimulation and bradycardia. You need to know what their cardiac reserve is.
Let's talk about fasting status. The NPO guidelines. I assume the standard ASA guidelines apply here.
Yes, and you must state them in the exam. 2 hours for clear fluids, 6 hours for a light meal or formula, 8 hours for a fatty or fried meal. The 2-6-8 rule.
Here's the exam trap I've heard people discuss. Can I get away with being a bit lax on this because it's just a minor procedure or just a camera test?
Absolutely not. That's a huge trap. The exam answer is standard fasting guidelines must be strictly adhered to. In fact, you need to show you're thinking even more deeply. Miller warns specifically about gastric emptying issues in patients with long-standing diabetes, gastroparesis.
Right. So a diabetic patient who says they fasted for 8 hours might still have a stomach full of food from the day before.
Exactly. Their autonomic neuropathy means the stomach doesn't empty properly. So for a long-standing diabetic with poor control, you treat them as a full stomach. Even if they've followed the NPO guidelines, that might be an indication to intubate them rather than just sedate them.
Great point. Let's touch on some special patient groups, the elderly. What's the key concern?
Reduced physiological reserve is the umbrella term. But be specific. Their circulation time is slower. Miller notes that drugs take longer to reach the brain. Slower arm-to-brain time.
So if I push a dose of Propofol and nothing happens in 20 seconds and I get impatient and push another dose?
You've just overdosed them. The first dose hasn't even arrived at the brain yet. By the time the second dose hits on top of the first, they are profoundly apnoic and hypotensive. The mantra for the elderly is start low, go slow, and wait. They're also much more sensitive to the cognitive side effects of Midazolam, leading to postoperative delirium.
Okay, and the obese patient. We touched on the VQ mismatch in FRC.
Yes, but also remember the pure mechanics of their airway. They have a heavy, thick neck. When they lose consciousness, that redundant soft tissue collapses inwards immediately. And because of the weight of the chest and abdomen, they have that severely reduced FRC. Their oxygen tank is tiny. They desaturate in seconds, not minutes. They are the definition of a high-risk airway in this setting.
And finally, patients with liver disease. Long Cases has a whole section on this.
And for good reason. Liver patients are frequent flyers in the endoscopy suite for variceal screening, banding, things like that. You have three main problems to worry about. 1. Altered drug metabolism. Drugs, especially those metabolized by the liver, last much longer.
2 must be coagulopathy.
Correct. Bleeding risk during biopsies is high. You need to know their INR and platelet count. And 3, encephalopathy. They are extremely sensitive to sedatives, particularly benzodiazepines.
Why benzodiazepines specifically? I've heard this before.
They can precipitate or worsen hepatic encephalopathy. The mechanism is complex, but it involves the GABA receptors in the brain, which are already upregulated in liver failure. So Miller advises avoiding midazolam in patients with severe liver disease if possible, or using tiny, carefully titrated doses. Propofol is often a better choice as its metabolism is less dependent on liver function.
Right. Okay, let's move into Part D, choice of anesthesia. This is marked in our outline as exam gold. So how do I describe the different options available to me?
You must start by describing the continuum of sedation. The American Society of Anesthesiologists, the ASA, defined 4 distinct levels. You need to know these definitions by heart for the exam.
Okay, let's go through them.
Level 1 is minimal sedation, or anxiolysis. Here, the patient responds normally to verbal commands. Cognitive function might be a little impaired, but their airway and breathing are unaffected.
Level 2.
Moderate sedation, which used to be called conscious sedation. This is the key one. The patient responds purposefully to verbal commands, either alone or accompanied by light tactile stimulation. The crucial part of the definition is no interventions are required to maintain a patent airway.
So they're still breathing on their own just fine.
Correct. Now, level 3 is deep sedation. Here, the patient cannot be easily aroused, but will respond purposefully following repeated or painful stimulation. And here's the cliff edge. The definition includes the phrase, the ability to independently maintain ventilatory function may be impaired.
So that's the danger zone, the transition from moderate to deep.
That is the precipice. As soon as you cross from moderate to deep, which can happen in a matter of seconds with a drug like Propofol, you are effectively inducing general anesthesia, but without a protected airway. And the final level, of course, is general anesthesia, GA, a loss of consciousness where the patient is not arousable, even by painful stimulation.
And Miller notes there's been a real shift in the field here, hasn't there, away from the traditional moderate sedation.
A massive shift. Historically, conscious sedation with a combination of midazolam and an opioid like fentanyl was the standard. But there has been a huge move toward propofol-based deep sedation.
And why is that?
3 reasons. Better patient satisfaction, they remember nothing and feel better afterwards. Faster recovery and discharge times. And frankly, better operating conditions for the endoscopist. The patient is completely still. But it comes at the cost of that higher risk of airway compromise and apnea.
Is there a controversy here about who gets to give the propofol?
A huge controversy. This is the whole NAAP debate. Non-anesthesiologists administer propofol. Stolting discusses this at length. Can a specially trained nurse or the gastroenterologists themselves give propofol safely? The FDA label for propofol is very clear. It says it's for use only by persons trained in the administration of general anesthesia.
So anesthesiologists would argue it's unsafe for others to be using it.
The argument is that you need someone whose sole job, whose entire focus is monitoring the patient's level of consciousness, their airway, and their hemodynamics. You cannot safely perform the endoscopy and manage a deep sedation simultaneously. For the exam and for any high-risk patient, the answer is clear. Propofol sedation should be administered by a dedicated anesthesia provider.
Okay, so sticking with that safety principle, when do I, as the anesthesiologist, decide to just skip sedation and go straight to general anesthesia? What are the hard indications for GA? This feels like a classic exam question.
It's an absolute exam favorite. You need to have a must-intubate list in your head. It's about identifying unacceptable risk.
Okay, what's on the list?
Number 1, High aspiration risk. We've already covered this. Active GI bleeding is the classic example. Blood in the stomach equals a full stomach. Also, known bowel obstruction, severe GERD, or conditions like achalasia.
Number 2.
Uncooperative patients. This could be a child, an adult with severe anxiety or claustrophobia, or a patient with cognitive impairment or developmental delay who cannot follow commands or stay still.
That makes sense. What's number 3?
Complex or prolonged therapeutic procedures. Think of ERCP, which requires the patient to be prone or semi-prone for a long time, or a procedure like POEM, peroral endoscopic myotomy. Anything where you anticipate it will take a long time and the patient simply won't tolerate staying in one position under sedation.
And the last one?
Failed sedation. This is a judgment call. If you have given what you consider to be safe and appropriate doses of sedation and the patient is still fighting, agitated, or uncomfortable, you don't just keep pushing more drugs. That's how disasters happen. You stop, you reassess, and you convert to a controlled general anesthetic.
Excellent. That's a really solid, safe list for an exam answer. Now let's move into the room. Part E, intraoperative anesthetic management. Let's talk about our airway management strategies.
Okay, we're in the room. For a standard EGD under sedation, you have a shared airway. You almost always start with topicalization.
You mean like a lidocaine spray?
Exactly. A lidocaine spray to the back of the throat or a viscous gargle. Morgan highlights this. Why do we do it? It obtuns that gag reflex we talked about. This makes scope insertion more tolerable and often lowers the total dose of intravenous sedation you need to give.
And what about oxygen delivery?
It is mandatory. You never do sedation without supplemental oxygen. Standard nasal cannulae are the minimum. You can also get specialized bite blocks now that have a little oxygen port built right into them, which is quite clever.
I see a high-yield note here from Miller about something else. High-flow nasal oxygen, HFNO.
Yes, this is a real game changer, especially for high-risk patients. You might also hear it called TH-RIVE transnasal humidified rapid insufflation ventilatory exchange.
Okay, that's a mouthful. How does it actually help in this situation?
It provides very high flows of warmed humidified oxygen, up to 60 or 70 liters per minute. This does two very important things. One, it creates a massive reservoir of 100% oxygen in the pharynx and fills the lungs. This dramatically extends the safe apnoea time. If the patient stops breathing, their saturation stays up for many minutes longer, giving you more time to intervene.
And the second thing?
The high flow generates a small amount of PEEP, or positive end expiratory pressure. It's only about 5 to 7 centimeters of water, but it's often enough to splint the pharyngeal airway open, preventing it from collapsing, especially in an obese patient with OSA. It's a fantastic tool.
So if we decide to go to GA, the debate is LMA versus endotracheal tube or ETT.
And for an EGD, an upper GI endoscopy, the endotracheal tube, ETT, is almost always the preferred device.
Why not an LMA? It's less stimulating, easier to put in.
Because the LMA, by its very design, occupies the pharyngeal space. It sits right in the hypopharynx, which is exactly where the endoscopist needs to go. If you put an LMA in, the scope has to be squeezed past the LMA cuff. You are literally fighting for space. Plus, the LMA does not fully protect against aspiration if the stomach is full of blood or air from insufflation.
But for a colonoscopy?
For a colonoscopy, the airway is free. So an LMA, or even just mask ventilation, is perfectly acceptable if you're doing a GA. But for EGD, you tube them. Secure the airway, get it out of the way, and let the endoscopist do their job.
Okay, let's talk about the drugs. Sedation and drug consideration.
Right, the pharmacology. As we said, the texts describe a massive shift over the last decade. It used to be all benzodiazepines and opioids. Now, if you read Stolting, it's practically a love letter to Propofol. But for the exam, you can't just say use Propofol.
You have to be more nuanced.
You do. You say that Propofol is often considered the gold standard for outcomes. It has a rapid onset, a very rapid offset, and valuable antiemetic properties. It is perfect for a high-turnover endoscopy list, where efficiency is key.
I see a note here in Sculpting about something called Sedation. What was that?
Ah, yes. Sedation. That was a computer-assisted sedation delivery system. It was a machine designed to allow non-anesthesiologists to administer Propofol for endoscopy. It had built-in monitors and would titrate the drug based on the patient's response.
And what happened to it?
Stolting mentions it as an interesting technological development, but it was withdrawn from the market. It's a good historical point to mention in an essay to show you've read the text deeply, but the principle it highlights remains. Propofol is a powerful drug that needs very careful continuous monitoring.
What about the traditional cocktail, the Midazolam and Fentanyl combination?
It's still used. It's the classic conscious sedation mix. Midazolam provides excellent amnesia and anxiolysis. Fentanyl provides that visceral analgesia needed for colonoscopy. But here is the massive, enormous trap. Miller warns in no uncertain terms about synergistic respiratory depression.
This concept blew my mind when I first read it. I always just thought, oh, a little midazolam, a little fentanyl, perfectly safe.
And that is the trap. It is not an additive effect. It's not 1 + 1 = 2. With these drugs, it's more like 1 + 1 = 10 when it comes to respiratory depression. The dose-response curve for respiratory drive shifts dramatically to the left.
Why? Is it because they hit different receptors but ultimately depress the same respiratory center in the brainstem?
That's exactly it. So the exam tip here is crucial. If you are describing the balanced sedation technique, you must explicitly state that the doses of each drug must be significantly reduced by at least 50% when used in combination. If you write down the standard doses for both drugs given individually, the examiner will assume you have just rendered the patient apnoic in a dark room.
That's a vital point. And what about dexmedetomidine?
Dexmedetomidine is an interesting one. Long Cases mentions it. It's an alpha-2 agonist. It provides what's called cooperative sedation and some analgesia, but crucially, without significant respiratory depression. Patients are sedated but can often maintain their own airway and breathe spontaneously.
Sounds perfect. Why don't we use it all the time?
The downsides are its slow onset and its long recovery time. It's not ideal for a quick 10-minute diagnostic scope where rapid turnover is needed. It's much better suited for longer, more complex cases like an ERCP, where you want the patient to be calm and breathing spontaneously for an hour or more.
Monitoring. We've touched on this, but let's drive it home for the exam. What do I need to list?
You list the standard ASA monitors as non-negotiable: ECG, non-invasive blood pressure, NIPP, and pulse oximetry. But for the exam, you must emphasize, and maybe even underline, capnography. Miller states that it is now considered mandatory for any deep sedation in an OR environment.
And why is it so critical? Why isn't the pulse oximeter, the SpO2, enough?
Because pulse oximetry is a lag indicator. It tells you about oxygenation, not ventilation. If a patient who is receiving supplemental oxygen stops breathing, becomes apnoic, their oxygen saturation might stay at 98% for a minute or two. The oxygen in their lungs acts as a buffer. But the capnograph, which measures end-tidal CO2, will show you a flat line immediately.
So capnography measures breathing, while pulse oximetry measures the consequence of not breathing.
Beautifully put. Exactly. In that dark room where you can't see the chest moving well, that little waveform on the monitor is your lifeline. It detects apnoea before desaturation occurs, giving you a critical head start.
And a practical tip, how do you even measure CO2 if they aren't intubated?
You use specialized nasal prongs that have a CO2 sampling line built into them alongside the oxygen delivery ports. It's simple and very effective.
Long Cases also mentions a precordial stethoscope. Is that still relevant?
I think it is, especially for pediatrics or even just for your own peace of mind. You tape it to the suprasternal notch. Having that continuous audible breath sound is a very reassuring thing in a dark, quiet room. It's a low-tech backup that connects you physically to the patient's breathing.
Okay, we are deep into the procedure now. Part F, complications and emergencies. The outline says this is absolutely essential.
It is. This is where you prove you're a safe anesthetist. You need to categorize these in your mind and in your exam answer. There are anesthetic complications, and there are procedure-related complications.
Let's start with the big anesthetic one.
Hypoxia, caused, as we've said, by airway obstruction from the tongue or the scope, or by central hypoventilation from too much drug. Or you can have laryngospasm. This is a nightmare scenario. The scope or secretions touch the vocal cords under light anesthesia, and the cords just snap shut reflexively. You can't ventilate in or out.
And hypotension.
Very common, especially with Propofol. And remember why. Many of these patients are significantly volume depleted. They've been fasting, but more importantly, they've taken a powerful bowel prep, strong laxatives that have dehydrated them. You then give Propofol, a potent vasodilator, and their blood pressure can just fall like a cliff. Fluid resuscitation is part of the anesthetic plan.
Now, what about the procedure-related complications? This is where SDOS is a good reference.
The big one is perforation. The endoscope can literally punch a hole through the esophageal, gastric, or colonic wall. SDOS and Miller both warn you to look for the sign of free gas under the diaphragm on a subsequent X-ray.
But how would you spot that during the case itself?
If the patient suddenly becomes tachycardic, their abdomen becomes rigid and distended, and they become difficult to ventilate. But the classic sign mentioned in SDOS that you might pick up is of cutaneous emphysema. The air from the gut escapes into the peritoneum, tracks up the mediastinum, and you can feel this crackling, like Rice Krispies, under the skin of the neck and chest.
And if you find that, it's a surgical emergency.
It's an immediate stop. Call the surgeons. This is a life-threatening complication.
And what about vasovagal episodes?
These are very common during colonoscopy. As the scope stretches the mesentery, it stimulates the vagus nerve. This can lead to profound bradycardia, and in some cases, even a systole. The Anesthesia OSCE books highlight this risk. You absolutely must have atropine or glycopyrrolate drawn up and ready before any colonoscopy starts.
Okay, so let's go into that war room scenario you mentioned earlier. You're 5 minutes into an EGD, the patient is obese, ASA3, you've given some propofol, suddenly the pulse oximeter tone drops. It's not that polite, high-pitched beeping anymore, it's that low, ominous, falling tone. The screen says saturation is 88% and dropping fast. What is the cognitive flowchart? What do you do?
The first rule is that panic is the enemy. You have to rely on your training on the algorithm, and step 1 is counterintuitive for the gastroenterologist who is focused on the procedure. Step 1 is the procedure stops.
They must hate that, don't they? They're so close, they just want to finish up real quick.
They do, but you have to be the authority in the room. Your voice must be calm but firm. Scope out now, please. You cannot diagnose or fix an airway problem with a garden hose in the patient's esophagus.
Okay, the scope is out. The patient's saturation is still 85% and falling.
Now you assess the mechanism. Is it central apnea from the drug, or is it obstruction? In NORARA, with sedation, it is almost always obstruction. The tongue has fallen back and is blocking the pharynx.
So first maneuver is a jaw thrust.
An aggressive two-handed jaw thrust. This serves two vital purposes. One, it physically opens the airway by lifting the tongue off the posterior pharyngeal wall. Two, it is an intensely painful stimulus. That pain is often the best respiratory stimulant you have. Sometimes, just that action will cause the patient to gasp and take a breath. You can also apply pressure at Larson's point, just behind the earlobe, which is also very stimulating and can help break a laryngospasm.
And suction.
Yes, have suction ready. Clear any secretions from the mouth, but be gentle, don't go too deep and trigger more spasm.
And if the jaw thrust doesn't work, saturation is now 75%.
Positive pressure ventilation. Get a good seal with a face mask and bag him with 100% oxygen. If you still can't ventilate, if the chest isn't rising and you feel resistance, you are now in a can't ventilate emergency. You must call for help immediately, and your next step is likely a muscle relaxant like succinylcholine to break the laryngospasm, followed by immediate intubation.
And for the exam, the key is showing that stepwise escalating response.
Exactly. But you also add that early recognition via capnography prevents you from ever getting to the succinylcholine stage. If you wait for the pulse oximeter to drop to 85%, you're already a minute or two behind the event. The capnograph tells you the second they stop breathing.
Clear and decisive. That's what they want to hear.
Right.
Okay, let's move to Part G, post-procedure care. The procedure is done. Can we just send them back to the ward or home?
Not yet. They must go to a dedicated recovery area. We use a scoring system, like the Aldrete score, or a modified PAS, that's a post-anesthetic discharge scoring system, to assess their readiness for discharge. And in recovery, we are specifically monitoring for resedation.
What exactly is resedation?
It's particularly a problem with drugs that have a longer half-life, like Midazolam. The drug circulates, it can be stored in fat tissue, and then leach back out into the bloodstream later. So a patient might look perfectly awake and alert in the procedure room, you wheel them to recovery, and 20 minutes later they're fast asleep and obstructing their airway again. This is why a mandatory monitored recovery period is so important.
Makes sense. Okay, the final step, discharge criteria. This is another exam core topic. Miller has specific guidelines.
Yes, and you must know them. They must have stable vital signs back to their baseline. They must be alert and oriented to time, place, and person. They should have no significant pain and minimal to no nausea or vomiting. But the two big non-medical ones are absolutely critical for the exam and for real life.
What are they?
1, they must have a responsible adult escort. They cannot go home alone, no Uber, no taxi by themselves. Someone has to be there to take them home and look after them. And 2, they are given explicit instructions of no driving, operating machinery, or signing legal documents for 24 hours if sedatives were used. This is a medico-legal absolute. If they drive home and have an accident and you didn't document that you gave this specific instruction, you are liable.
Excellent. Now, let's wrap all this knowledge up with Part H comparison and exam integration. I love a good table. Let's compare endoscopy, EGD versus colonoscopy for the exam paper. How would we structure that?
This is a fantastic way to present your answer. It shows you can synthesize information. You draw a simple table with 2 columns.
For EGD, you write shared obstructed airway, high risk. For colonoscopy, you write Airway is free and accessible.
For EGD, it's gaglaryngeal reflexes. For colonoscopy, it's visceral pain from distension.
For EGD, you write aspiration. For colonoscopy, you write dehydration from prep and vagal tone stimulation.
That's perfect. And the same for sedation versus general anesthesia.
Another great table.
Under pros, you write faster turnover, less invasive, fewer side effects like sore throat. Under cons, you write unprotected airway, variable depth of sedation, risk of obstruction.
Under pros, you write secure protected airway with an ETT motionless field for the endoscopist. Under cons, you write more hemodynamic instability, longer recovery, risk of post-op nausea, and sore throat.
Before we close out, let's hit some of those common exam questions and Viva traps you mentioned. Trap number 1. Can I just do this under local anesthesia?
The trap is to say yes, of course. The safe and correct answer is only for a very specific, highly cooperative patient for a brief diagnostic procedure. And even then, you would usually want an anesthesiologist on standby, ready to provide sedation if needed. You cannot do a complex EGD on an anxious patient with just a bit of throat spray.
Trap 2. Ignoring the bowel prep.
We mentioned this, but it's a common Viva question. The examiner says, your patient's blood pressure is 90/60 on induction. Why? You must mention. The patient is likely significantly dehydrated from the bowel preparation. If you just blame the propofol and miss that key piece of physiology, you lose marks.
And trap 3. How do you monitor respiration in a darkened room?
If you say, I watched the chest rise and fall, you fail. The answer is primarily with capnography, which directly measures ventilation, and secondarily with the audible pulse oximetry tone, which reflects oxygenation. Miller is very specific on this.
Finally, let's talk about presentation. You mentioned diagrams.
Yes. If you have time in a written exam, a simple diagram gets you extra marks. Draw the Shared Airway setup, a simple line drawing of a patient's head in the lateral position, showing the nasal cannula providing oxygen, the bite block in the mouth, and the endoscope going in, clearly separate from the trachea. You can also draw the flow chart for desaturation. A box saying SpO2 falls, with arrows leading to start procedure, then to stimulate and jaw thrust, then to bag mask ventilate, and finally to intubate. Visuals are powerful.
Fantastic. Okay, let's summarize this whole session for that final 15-mark answer. What's the checklist?
Here is your summary checklist. Your concluding paragraph should hit these points.
Safety standards. NOR-OR safety standards are identical to OR standards. No shortcuts are permissible.
Pre-op assessment is paramount, with a specific focus on the airway and high-risk comorbidities like OSA, cardiac, and liver disease.
The shared airway is the primary anesthetic challenge in EGD.
Monitoring. Continuous capnography is mandatory for detecting apnea early.
Technique. Propofol is the modern workhorse agent, but you must understand the entire sedation continuum and the synergistic respiratory depression trap with benzos and opioids.
Complications. You must be prepared to manage hypoxia decisively and be ready to convey it to a general anesthetic if patient safety is ever compromised.
And to leave our listeners with something to think about, a final provocative thought.
The debate continues, and you'll see it in Stolting and Miller regarding non-anesthesiologists administering propofol. Is it safe? In young, healthy ASA1 patients, maybe the data supports it, but in the sick, elderly, obese, complex NORA population that we see more and more of today, does it compromise the fundamental safety-first principle of our specialty? It's something to think about as you study and form your own professional opinion.
That's a wrap on this deep dive. You have the notes, you have the strategy, and you have the mindset. Now go ace that exam.
Safety, preparation, vigilance. Good luck.